We'll be discussing on von Willebrand disease in this particular section. Von Willebrand disease, why we are discussing as a separate video is because I believe it's in between a bleeding disorder, clotting disorder, because certain instances it can behave like a bleeding disorder, and in some instances it can behave like a clotting disorder also. There are some types which can behave like a clotting disorder. The reason why it can behave like a bleeding as well as a clotting disorder is because it has two functions. One, it binds with the GP1B of the platelets and helps in platelet addition. And second, it also carries factor VIII and prevents its degradation in the circulation. That's why it's important for the half-life, maintaining the half-life of factor VIII. So that's why sometimes it can behave like a clotting disorder. But anyways, so this, at least theoretically, is actually a bleeding disorder, which means it has to be discussed along with the platelet disorders, but let's be different. So this theoretically, it is a bleeding disorder. And one of the important trivia that you have to know about the von Willebrand disease is the fact that it is the most common inherited bleeding disorder. It is the most common inherited bleeding disorder in the world. So this is a very, very important point that you have to know. So before moving on to the actual problems that happens in von Willebrand disease, let us see how the von Willebrand factor is synthesized and processed and released from the endothelium. Remember, your endothelium is going to be the major source. Your endothelial cell is going to be the major source for von Willebrand factor, in the sense the vascular surfaces, the endothelial cells from everywhere in the body are the major sources of von Willebrand factor in the body. It's not the liver. Please do understand. Fine. Now, how the von Willebrand factors are synthesized? They are initially synthesized in the form of monomers. You can see here, they initially synthesized in the form of monomers, which are then processed into multimers, and these multimers are the ones that are released into the circulation. Please do understand that multimers are actually more effective than the monomers. The monomers are generally not that effective. The multimers are the ones that are going to be extremely effective compared to that of the monomers. So how the process of multimerization form? But let us see the structure of the von Willebrand factor initially. So initial structure of von Willebrand factor is very simple. You can see it's a monomer containing many different proteins. The initial one is called a signal peptide, the last one is called a CK domain. And then you have various D domains, clear? So these are the D domains which are shaded in green, and you have A domain and a C domain separately. So you have signal peptide, CK domain in the first and the last, then you have various ends, you have D domains, then you have A domain and C domains also. So because these are important, because these are the ones that are going to bind with a particular molecule that is important. I mean, for the addition and all this, factor VIII carrying function, all these things. So let us see what are the important domains that you need to know. You can see here, the A domain is the one, you can see very clearly, the A domain is the one that binds with the GP1B and also the collagen. Clear? So this is the domain that's going to bind with the GP1B, that's also going to bind with the collagen. Because we have studied till now, let us put a diagram. So we have studied that platelet has this GP1B receptor, this is the platelet, and this von Willebrand factor is going to form a glue between the subendothelial collagen. This is the endothelial cell which is disrupted, this is the subendothelial collagen which binds to the von Willebrand factor. The von Willebrand factor in turn glues this subendothelial collagen and platelet GP1B receptor, and this interaction is important, I told you, for platelet addition. We have discussed in detail about the basics of hemostasis. But which domain, if you ask me, that binds with the platelet GP1B receptors as well as the subendothelial collagen is the A domain. A domain is the one that's going to bind. So you might ask me how a single von Willebrand factor which is having one A domain can bind with the platelet GP1B as well as the subendothelial collagen, and that is where your multimers come into play. Which means when you are going to form a multimer, let us see this diagram again. The moment when you are going to form a multimer, this is going to have several A domains, isn't it? They are going to have several A domains, which means one end can easily bind with your GP1B. For example, let us assume this binds with your GP1B, and the other portion of the multimer can bind with the collagen. Clear? So it's simple. So that is the reason why I told you the multimers are the ones that are more and more effective compared to the monomeric forms. You have to be very sure about that. Clear? And you can see this D domain is the one, and especially this D3 domain. It's a very important point. This D3 domain is the one that is going to bind with the factor VIII and prevents its degradation. Thereby, this is very, very important. This binding is very important for increasing the half-life of factor VIII. Clear? Thereby preventing its degradation. At the same time, there is a minor one called this C domain. This C domain is the one that's going to bind with this alpha 2b3. What do you mean by alpha 2b beta 3? This is nothing but GP2b3. This, I don't know how many of you remember, because in basics of MS, as I told you, for platelet aggregation for 2b and 3a, the most important thing you need is fibrinogen. All right, I'm not telling no, but remember, to an extent, your von Willebrand factor also can form this effect. This I told you already, but anyways, so the most important is the fibrinogen for this platelet aggregation. But anyway, von Willebrand factor is most important for platelet adhesion only than aggregation. But this is a minor thing that also you have to know. This binding with the GP2b3A function is also very important. So these are the important domains of von Willebrand factor. Remember, A domain binds with the collagen and GP1b, and your D3 domain is the one that carries the factor VIII like a kangaroo, and your C domain is the one that's going to bind with the GP2b3, which is a very minor function of von Willebrand factor. So now I told you the importance of, the multimers of von Willebrand factor. Let us see how the multimers are formed. The first step in forming the multimers is something called dimerization. First, they have to form the dimers, and this dimerization process happens in the endoplasmic reticulum. Let us review very quickly. During dimerization, your initial signal peptide molecules will be cleaved. So now the disulfide bonds will be formed within the CK domain. So this is the CK domains. So now the disulfide bond will be formed between the CK domains, and the signal peptides will be cleaved, and the resultant von Willebrand factor dimer will be formed. Now there will be dimers, and this dimer will become multimers in Golgi apparatus. Further processing the Golgi apparatus will make the dimers into multimeric form. How they form multimers is by cleaving the D1, D2 peptides. These are called propeptides, and these D1, D2 are actually cleaved enzymatically, but still they remain attached to the von Willebrand factor multimer through non-covalent interactions. They are not going to be bound by covalent bond, but they are bound through non-covalent interactions, even after they are enzymatically cleaved from the original von Willebrand factor multimer. So how will you form multimers? Multimers are formed by this particular principle. You have a lot of dimers actually. These dimers are already formed in the endoplasmic reticulum, you know that. Now these dimers are going to form disulfide bridges with each other at your particular D3 level. So at your D3 level, these dimers are going to form disulfide bridges. So this is how von Willebrand factor multimers are formed. So once the von Willebrand factor multimers are formed, they are actually coiled. They will be stored as coiled helices. This is not given here, but it's actually stored as this kind of coiled helices in the Weibel pallet bodies within the endothelium. So when they wanted to be released, these Weibel pallet bodies will fuse with the endothelial membrane, will fuse with the cell membrane, and they are going to be uncoiled. First thing, they are going to be uncoiled. They will be uncoiled and they will be released into the circulation. Clear? So once they are, one important point that you have to notice, remember that von Willebrand factors that are coiled, these coiled helices are actually inactive. They cannot be active. And these uncoiled von Willebrand factors are the ones that are active forms. So which means these uncoiled von Willebrand factors are the ones that are active forms, and the coiled ones that are present within the Weibel pallet bodies are generally not active and they are inactive. And once they are released into the circulation, these molecules which I tell you, these are called Adams 13. Clear? This is an enzyme. This is a metalloprotease like enzyme. So this Adams 13 enzyme is going to cleave the von Willebrand factor back into monomeric form and dimeric forms, which means it's going to cleave the multimers into inactive forms, less active forms at least. Whenever you have deficiency of this Adams 13, you are going to result in a very peculiar type of disease called thrombotic thrombocytopenic purpura, TTP. Rather than calling a deficiency of Adams 13, you can call as reduced Adams 13 activity. So this is going to result in a disease called TTP, which we are going to discuss as a separate event, not in this von Willebrand disease. So where von Willebrand disease can happen? Von Willebrand disease can happen first of all in reduced synthesis. The von Willebrand factor monomers itself will be synthesized in a very reduced manner, or the multimerization can be defective. Clear? or the storage can be like more effective, which means it's not released at all. So which means reduced release is also one of the reasons why you get a von Willebrand disease. So reduced synthesis or reduced multimerization or reduced release, all these things play a key role. And reduced synthesis of von Willebrand factors typically happens due to null mutations, which means some stop codon will come into it, and because of that the von Willebrand factor will not be synthesized. Or the quality of the von Willebrand factor can be altered by mutations at various places. For example, there are basically 3 types of von Willebrand disease. You have type 1, type 2 and type 3. We are going to discuss in great detail about all these types of von Willebrand factor, but let us give you an orientation about what is a von Willebrand disease, what are the types of von Willebrand disease. So first, in type 1, it is a quantitative deficiency. In type 3, again it's a quantitative deficiency, but type 2 is predominantly a qualitative deficiency of von Willebrand disease. It's not a quantitative, it's a qualitative. The problem is the von Willebrand factor quality, not the quantity. In type 1 quantitative, it is not complete loss. There is reduced synthesis of von Willebrand factor will be there, but it's not complete loss of synthesis. But here in type 3, it's complete loss of von Willebrand factor, which means type 3 is going to be the most severe form. It's a complete loss of von Willebrand factor. Clear? But this type 2 is going to have a lot of different types. Like you have type 2A, type 2B, type 2M and type 2N, otherwise referred to as something called a Normandy. So let us give a brief idea about what are these types. 2A, I told you all these are qualitative defects, they are not quantitative defects, which means the actual levels of von Willebrand factor may be normal, but there are problems in the quality of the von Willebrand factor. That's where the issue is. In 2A, these patients will have reduced adhesion to the platelets from von Willebrand factor. At the same time, they will have reduced multimer formation. These high molecular weight multimers that are formed from von Willebrand factor initially will be reduced. They won't form multimers properly. Type 2B is one peculiar disease where you have increased platelet adhesion. Like you can see, this also will have reduced multimers, that's all right. But that is not a very important point here. They will have increased platelet adhesion, that is what the key here. This is only type of von Willebrand disease which is due to increased platelet adhesion. You can ask me how increased platelet adhesion can cause the disease. Actually, yes, whenever the adhesion capacity of von Willebrand factor to the platelets are increased, they are going to sequester a lot of von Willebrand factor towards the platelets, so that both the platelet levels and von Willebrand factor free levels will be reduced. So during times of, like when the clotting process has to be activated, that time you will not have sufficient von Willebrand factor and platelets to seal the clot, to seal the area. So you might still result in a bleeding disorder. So this is a very peculiar thing. So this is a 2B type. And then you have 2M. 2M is the place where you have reduced adhesion of von Willebrand factor towards your platelet GP1B. But what is the difference between 2A and 2M? If I ask you, you have to tell these patients will have a normal multimer formation. So that is a major difference. But still they will have reduced adhesion. 2N is again a very, very peculiar thing. They can even behave like a clotting disorder or the hemophilia, where the patient will have absent factor 8 binding. Say they will not bind with factor 8 at all, which means the problem is von Willebrand factor activity, everything will be normal, but the factor 8 levels will be low, which means it is going to behave like a hemophilia most of the time. So it's a severe disease and it's going to behave like a hemophilia A most of the time. So that is these are the differences between different types of von Willebrand factor. And again, most common form is type 1 only, almost 85% is type 1 only. And second most common form is the type 2 form, 10 to 15% is type 2 only. And less than 5% are type 3 forms, which means the severe most disease. The most severe is actually type 3 only, complete absence of von Willebrand factor, and they cannot carry any, like factor 8 also. So factor 8 levels also will be too low in type 3 disease. So the most severe form is type 3 only, and they are very rare, fortunately, less than 5%. The most common form is the type 1, which is actually a partial quantitative deficiency, not a complete deficiency, but a partial, it may be severe also, but a partial deficiency of von Willebrand factor. Clear? So these are things that are going to happen. So the mutations can happen at many places, as I told you. It could be reduced synthesis of von Willebrand factor, or reduced multimeric formation, or it can be reduced release of von Willebrand factor also. But the qualitative defects can be like different. For example, if you have your A1 and C domain mutations. For example, A1 and D3 domain mutations. Let us see, if you have a A1 domain mutation, you might result in either increased affinity or increased binding with GP1B, or you can have a reduced affinity of GP1B. So this, whenever you have this A1 domain mutations, you might result in either a von Willebrand disease 2B, or you can result in a von Willebrand disease 2M. So 2B is due to increased affinity of von Willebrand factor to GP1B, and 2M is due to reduced binding of von Willebrand factor to GP1B. Clear? We know that. And typically, if you have mutation in the D3 domain, so this mutation in the D3 domain will result in this typical 2N type of disease, Normandy, where you are going to have poor binding of von Willebrand factor with factor VIII, so it can behave like a hemophilia. Remember, 2A type of disease is different. 2A is not going to be due to your A1 or D3 mutations. 2A is going to be due to defective synthesis at the same time. Because of defective synthesis, they will have poor quality at the same time. They will have poor adhesion capacity with platelets. At the same time, they will also have a poor multimer formation. That's a completely different disease. So, A domain mutations will result in type 2B and type 2M, and this D3 domain mutations will result in type 2N von Willebrand disease. So, these are the different things that you have to note about the von Willebrand disease. So, some basic data I have given. So, let us go in detail now. Let us pick up more details about the von Willebrand disease. So, first, what are the functions of von Willebrand disease? Sorry, functions of von Willebrand factor. Then go to the clinical features of von Willebrand disease. Functions of von Willebrand factor, I told you, number one, they are going to cause platelet adhesion. Second, they are going to carry factor VIII. It's a factor VIII carrier which increases the T half of factor VIII. Platelet adhesion by binding with GP1B. Because this von Willebrand factor, we call it as a platelet glue. It glues the platelet with the endothelial collagen by forming like a glue in between. Number three, apart from that, it can also help to an extent in platelet aggregation. But even though this is not a very important function, these are the two most important functions of von Willebrand factors, to be honest. Fine. What will be the clinical features? Or there is some entity called an acquired von Willebrand disease. So this is a new terminology which is upcoming recently in many papers. So what is acquired von Willebrand disease? I am not talking about a congenital deficiency. Acquired von Willebrand disease can happen in many conditions like malignancy. Typically, the moment I tell malignancy, it must be some hematopoietic malignancy, typically a lymphoproliferative malignancy like a non-Hodgkin lymphoma. Lymphoproliferative malignancies, what they do is they might have increased clearance of this von Willebrand factor. That is the reason why they might have a von Willebrand disease like picture. Then myeloproliferative neoplasms, especially those myeloproliferative neoplasms which have increased platelets. Typically, polycythemia vera and your essential thrombocythemia are the two conditions which are going to have increased platelets, thrombocytosis many times. So this thrombocytosis, at the same time, these are abnormal platelets. They might have more affinity for this von Willebrand factor, this GP1B, that are found in these conditions. So they might trap excessive von Willebrand factor and they might reduce the levels of von Willebrand factor, and that is the reason. Due to von Willebrand factor sequestration, that is the reason why you get von Willebrand disease in myeloproliferative neoplasms as well. Then you can develop in autoimmune disorders. Obviously, the fact is due to autoantibody development against this von Willebrand factor. Then hypothyroidism, again due to autoantibody formation, because hypothyroidism is often associated with autoimmune conditions. And a lot of drugs can result in downregulation of von Willebrand factor production and synthesis. And then you have one important syndrome called Hades syndrome. Hades syndrome. Hades syndrome happens in patients who are having severe aortic stenosis. Remember, so since the valve is severely stenotic and left ventricle is generating very high force, because the shear stress, because of so much of with the force, the blood will be moving against a very narrow orifice in aortic stenosis. So this, like jet velocity and the shearing of the blood that is going through a narrowed orifice might break down this multimers of von Willebrand factor. So might result in a poor multimer circulation in the blood. So because of that, you might get a von Willebrand disease. Clear? So this Hades syndrome also has some peculiar features. They are also associated with colonic AV malformations. Your arteriovenous malformation in the colon is very common with Hades syndrome in patients with severe AS, which might result in severe lower gastrointestinal bleed also. Because already these patients will be deficient in functional von Willebrand factor. So coupled with that, they have a colonic AV malformation which bleeds, it cannot stop easily, so might result in a severe lower gastrointestinal bleed. Number 7, you can result this same kind of pathophysiology that can happen in LVAD. These are left ventricular assist devices. These are mechanical devices. When the blood passes through these mechanical devices, again Von Willebrand factors may be broken down and destroyed because it's a mechanical device. So these are the conditions where you might get acquired Von Willebrand disease. Again, this could be a very important question for the future. Now let us move on to the clinical features. Clinical features of Von Willebrand disease. Clinical features, obviously the patient will present similar to a bleeding disorder. There is no doubt about that. They will present like a bleeding disorder, usually like a mucous membrane bleed. This is characteristic of a bleeding disorder. Like epistaxis, menorrhagia, simple. Then they also bleed a lot from skin cuts and abrasions. Obviously, this is again very similar to a bleeding disorder. So, bleeding after skin cuts and abrasions. But very importantly, in exam, they will ask you one important finding, that is bleeding after tonsillectomy. Bleeding after tonsillectomy. This excessive bleeding after tonsillectomy, I don't know. This can happen in other clotting factor disorders also, but I really don't know how much this is important. In exam, this is a very stereotypical question. If they tell bleeding, excessive bleeding after tonsillectomy or a dental procedure, excessive bleeding after tooth extraction, dental procedure. If they give these two histories, you can, with closed eyes and blind eyes, you can tell it's a Von Willebrand disease, at least. Unless until you don't have any clear-cut feature of a clotting disorder, then with closed eyes, blindly you can tell bleeding after tonsillectomy, excessive bleeding after dental procedure like tooth extraction is equal to Von Willebrand disease in exam. This is stereotypical and universal. So apart from that, they behave like a bleeding disorder, which I told you already. Clear? But severe diseases like type 3 and type 2N forms might behave like a hemophilia also, like hematomas, your hemarthrosis. All these things are also possible and can happen, but very rare. But in general, they behave like a typical bleeding disorder. That's what you have to know. In general, remember, females have more severity, and females are the ones that are very commonly affected by the disease. We don't know why. Females are very commonly affected, and severity is more in females, which is quite opposite of the hemophilia, where males will be more affected, males will have more severe disease. But this is quite opposite. And I told you hemophilia-like presentations will happen in only two disorders, two types of Von Willebrand disease, that is type 3 and type 2N. So these are the two types of Von Willebrand diseases which can have a hemophilia-like presentation. Okay, now let us see what will be the presenting feature of and what are the clinical features of each and every single type of Von Willebrand disease. Let us put the type and let us put the inheritance pattern. Maybe you can write along with that. Then what will be the defect and what will be the bleeding severity, and what is the probable mutation that you expect in this type. And you have something called ristosylin-induced platelet aggregation. This is very important Von Willebrand factor, that is called REPA. What will happen to REPA? And there is something called Von Willebrand factor ristocetin cofactor assay. So you see the ratio of that. So then you have Von Willebrand factor antigen assay. So remember, this is detecting the actual levels of Von Willebrand factor. This is going to tell you the actual levels of Von Willebrand factor, but this cofactor assay is going to tell you the activity levels of Von Willebrand factor. Activity what is the actual activity of Von Willebrand factor that is present in the plasma as of now? That's what the cofactor assays will tell. Antigen assays will tell the exact levels of Von Willebrand factor that is circulating right now. Then you have factor 8 levels. That is also very important to know. Then you can see a ratio of Von Willebrand factor ristosylin cofactor assay versus Von Willebrand factor antigen assay. Both you can see the ratio because this is a functional ratio. What you are seeing is level to function difference. Whether is there any difference between Von Willebrand factor levels and Von Willebrand factor function? Is there any mismatch? If the levels are also low, the functions are also low, the ratio will be less. But if the levels are okay, only the function is low, clear, you might have even an increased ratio. So that is why that is very important for certain conditions. And next thing what you have to know is whether multimers are there or not. That's what you see. Multimers are there or not. And finally we can see whether we can make out any comments. So So let us construct the table. So let us explain one by one. So first you're going to have your type 1 von Willebrand disease. This type 1 von Willebrand disease typically is autosomal dominant inheritance. I told you again the defect is partial and quantitative defect. Always remember this is a partial absence, partial quantitative loss of von Willebrand factor. It's a quantitative but partial loss, not a complete loss. Bleeding tends to be usually mild or none. No bleeding to mild bleeding. But they can have severe bleeding if there is a severe type 1 deficiency, but that is very rare. You don't get it. And you have type 2 itself, you have type 2A. So what do you mean by type 2A? Again, it's a qualitative defect where you have reduced platelet adhesion. At the same time, you will have reduced multimer formation. So this is type 2A. This is the defect. And type 2A tends to be autosomal dominant. The entire process, this type 2 itself, all the type 2, not only this type 2A, all the type 2 may be autosomal dominant or recessive. We shall see that. And you have type 2B defects. Type 2B defects, as I told you, again it's a qualitative defect. It's increased adhesion with GP1B. At the same time, they will have reduced multimer formation. So this is again a qualitative defect. Type 2M, again I told you it's a qualitative defect. And here you are going to have reduced platelet adhesion, but you will have normal multimers formation. And you have type 2N, this is Normandy type. Again it's a qualitative problem where you have entire von Willebrand factor binding, everything will be normal, but one problem is it cannot bind with, no binding with factor 8. It's a very poor factor 8 binding. So that is the problem. And they have normal multimers, everything will be normal. Only thing is the poor binding with factor 8. And finally type 3 is there. It's a severe quantitative deficiency, which means it's a complete loss of von Willebrand factor, complete loss and absence of von Willebrand factor in the patient's blood. So these are different types. In that, type 3 tends to be autosomal recessive inheritance, and type 2 can be autosomal recessive or it could be autosomal dominant also. But very commonly it is autosomal dominant, but it could be autosomal recessive or autosomal dominant. But the most common form, as I told you, is going to be the type 1. 85% of the von Willebrand disease will be this partial quantitative loss only, that is type 1 von Willebrand disease. Bleeding tends to be severe in case of type 3 disease, whereas here it is moderate to severe. It's not mild also, it's not no bleeding also, it's moderate to severe. Very commonly the severe bleeding will happen in this type 2N disease because it will behave similar to hemophilia. And if they ask you what are the von Willebrand diseases that behave similar to hemophilia, it is 2N and 3. These are two things that might behave similar to that of a hemophilia. So mutation wise, it is formation of null alleles, which means stop codons will be formed, null alleles will be formed, so that you cannot get any synthesis of von Willebrand disease. Or it could be missense mutations. These missense mutations may result in reduced release of von Willebrand factor, intracellular trapping of von Willebrand factor. So that is the reason reduced release. Because of reduced release, you might result in reduced circulating von Willebrand factor. That's the problem. Type 2A is due to missense mutations, but except any missense mutation anywhere in the von Willebrand factor chain may result in type 2A disease, but the exception being this A1 and D3 domains. Remember type 2B, it's a missense mutation, typically in A1 domain. Again type 2M is a missense mutation, and again typically is going to happen in A1 domain. And type 2N is again a missense mutation, but here is going to happen in D3 domain. Remember A1 domain is important for binding with GP1B. That is the reason why if it's gain of function mutation, you will have increased adhesion. If you have loss of function mutation, you are going to have reduced adhesion. That's it. It all depends on what is the type of mutation. And D3 is going to bind with factor 8, you know that. That's why D3 mutation will result in defective factor 8 binding. Here, again, the only one mechanism is formation of null alleles, which means complete loss of synthesis. So these are the mechanisms, these are the genetic mutations that are underlying the different types of von Willebrand disease. Now, what will mean by type 1 disease? Type 1, your restore-induced platelet aggregation will be low. Type 2A, REPA will be low. Your type 2M, REPA will be low. Type 2N, REPA will be low. And again, in type 3, obviously, REPA will be low. But remember, only type which has increased REPA is this type 2B. Very, very important point. This 2B is the only one disease that is going to have this increased testosterone-induced platelet aggregation. That is the reason why this type 2B is also referred to as something called a pseudo-Wandelbrand disease, because they have high REPA, because I told you they have increased platelet adhesion. That's why. Then Wandelbrand factor, testosterone cofactor activity, we are talking about the circulating Wandelbrand factors. We are not talking about what are the actual total body Wandelbrand factor, what are the Wandelbrand factors that are circulating, and what are the levels of those, and what are the functional activity. So this will tell you, this antigen will tell you the actual levels of circulating Wandelbrand factor, and this testosterone cofactor Wandelbrand factor assays will tell you what is the functional activity of Wandelbrand factor. Functional activity, that is circulating Wandelbrand factor. We are not talking about the what is the Wandelbrand factor that are bound already, doesn't matter. In type 1, it will be definitely low. Wandelbrand factor, testosterone cofactor will be decreased, but remember in type 2M, 2N it will be normal. I told you here the only problem is the fact that the factor VIII cannot bind with Wandelbrand factor, but apart from that, the actual activity levels of the circulating Wandelbrand factor will be normal only. There will be no doubt. Testosterone cofactor binding activity will be completely normal. And obviously here it's complete loss, so it will be decreased. Wandelbrand factor antigen levels. We are talking about the actual, not activity, the levels now. Again here it will be decreased. 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 Here also it will be severely decreased. Here I can tell it will be severely decreased in this because it's almost complete deficiency. Clear? So, but here it will be normal again, because in type 2N, again I told you the only problem is poor binding with factor VIII. That's all, nothing else. Apart from that, everything else is normal in type 2N. Then what about the factor VIII levels? Factor VIII levels, maybe normal or mild decrease will be there. It can be normal or mild decrease will be there. Again, it will be normal or mild decrease will be there. Again, it can be normal or mild decrease will be there. But in these two settings, it will be seriously impaired. Factor VIII levels will be very, very low, because here they cannot bind with factor VIII at all, so they cannot carry factor VIII, means the half-life of factor VIII decreases dramatically and they are going for more and more destruction. So levels will be so low. And number 2, in type 3, there is no Wandelbrand factor at all to carry this factor VIII, so that is the reason why the levels are going to be extremely low. So these are two conditions where the factor VIII levels will be seriously reduced. That's why they behave like a hemophilia sometimes, this type 2N and type 3. If you take the activity levels, like this cofactor, I mean, we are actually seeing the functional activity versus the comparing with the actual factor levels. Here the functional activity will be okay because it's only a partial deficiency, but the actual levels will be a little bit low, resulting in a ratio of more than 0.6. Here it will be less than 0.6, here it will be less than 0.6 again, and here again it will be less than 0.6, but here it will be more than 0.6 again. This is a very important point, because again everything will be normal here. That's what I'm telling you. Everything will be normal except for the factor VIII binding. And here you cannot, there's no point, because you cannot even compare, man. It's 0. This also 0, this also 0. What you will do? Both are 0. There's no point in telling the ratio of 0. It's not applicable here. It's everything, you cannot detect a Wandelbrand factor. Then how can you find out this activity measurements and all? Multimers are generally normal. At least the pattern of the multimers. Because the pattern is there in electrophores, you can see different types of multimers are there. It's not only, even though we discussed only multimer as a whole, there are different types of multimers that are available for Wandelbrand factor. Different groups of multimers are there. All are high molecular weight multimers, and that pattern at least will be normal. Even though actual level of Wandelbrand factor is low, but the pattern they form is normal. Clear? And here I told you the multimers will be absent. There won't be any multimer formation at all. In 2B also there won't be any multimer formation, so it will be absent. In type 2M, I told you it's a normal pattern. That's the one that differentiates between type 2A and type 2M. So both are reduced platelet adhesion, but the multimer formation is normal in type 2M. Here you have a normal pattern of multimers again. Again, told you everything is normal here except for the fact that they don't bind with factor VIII, that's it. But here, completely absent. Again, it's a total loss of Wandelbrand factor, which means it's complete absence of multimers. And what about the commons? Commons, if you see, you can have a look at something called Wandelbrand factor propeptide. This is called propeptide. PP means propeptide levels. where it will be more than 5 international units per deciliter. This is a very important point. Why? Because there is an entity called severe type 1 disease. And obviously type 3 tends to be very severe, where von Willebrand factor propeptide activity tends to be less than 5, which means it's completely absent. Less than 5. At least here, because it's a partial loss, at least propeptide levels will be maintained at more than 5, even though it's decreased. But here the propeptide levels will be less than 5, which means the complete loss of any form of von Willebrand factor in the blood. Then 2A, I don't think you have to know something. And 2M also you don't need to do anything, because both resemble almost the same except for the multimer difference. And in 2B type, 2B, here you have thrombocytopenia. Many times you can have a thrombocytopenia. So this is the only type of von Willebrand factor, von Willebrand disease, that is going to have a thrombocytopenia, which I have discussed again already. And in this this particular 3N type, remember they can clinically resemble hemophilia. Clinically may resemble hemophilia because everything will be normal. So again, this also can resemble a hemophilia. This also can resemble hemophilia. Clear? So this is what you are going to see. And remember, everywhere, if you want to know the exact values, I told you it's decreased only. But in all these conditions, the activity levels it's decreased means it will be less than 30. I mean, whatever shaded in blue means less than 30. Restorsion cofactor activity as well as the actual antigen levels will be less than 30 international units per deciliter. But here it will be more than 30. Definitely it is normal. But here it will be so low that it will be less than 3. It will not be even less than 30. There is no point. It means complete absence. Here it is at less than 3 in fact. It's so low. Clear? Let us put all this into a algorithm fashion so that you will understand each and every type, how to assess and how to differentiate them. So let us assume a patient is having a suspected von Willebrand disease. And when you suspect a von Willebrand disease, when they are going to present like a bleeding disorder, clinically, you have normal platelets, normal PTINR, and normal or slightly decreased factor 8 and normal or slightly increased APTT. Normal or slightly increased APTT, and these patients will have a abnormal PFA 100. Abnormal PFA 100 test. So this is, this is where you classically think it could be a von Willebrand disease. So whenever you have a suspicion of, even though this can be so much different and highly variable between different types of von Willebrand disease, but let us assume these are the usual typical ways how you suspect a von Willebrand disease. So whenever you suspect von Willebrand disease, the next step I am going to do is my von Willebrand factor, restorsion cofactor activity assay, and your von Willebrand factor antigen assay. So the results can be coming as it is normal or it can be decreased. If surprisingly if your reports are normal, then the next step, do factor 8 levels. Factor 8 levels. Factor 8 levels again can be normal, or factor 8 levels may be reduced. So if factor 8 levels are normal, think about other bleeding or coagulation disorders. Some rare bleeding or coagulation disorder types will be there. So you have to think about all others. If factor 8 levels are decreased, then it could be hemophilia also, which can present similar to normal, von Willebrand factor levels might be associated with hemophilia as well. So here the idea is to mainly confirm or rule out hemophilia. That you can do by doing something called von Willebrand factor and factor 8 binding assay. This is what I am going to do, binding assay, where this binding assay will be normal in case of a hemophilia. It's a typical hemophilia A, normal, where the binding assays will be abnormal, which means the binding between von Willebrand factor and factor 8 will be low in case of a type 2N disease. That's a Normandy. Type 2N disease, it tends to be abnormal. Okay, now you know that von Willebrand factor, restorsion cofactor activity in von Willebrand factor, antigen assays are low and abnormal. In this condition, see what is the value. What is the quantitative values? what is the quantity of von Willebrand factor, restoration cofactor activity and antigen assays. If it is less than 3 or if it is less than 30, which means more than 3 but less than 30. Less than 3 means definitely it's a type 3 disease, very severe disease. If it's less than 30, then you have a lot of like things that come under this group, like you have a 2A, 2B disease, 2M disease and type 1 disease also. All these things are going to come under this pool. So next step is to look for the multimer analysis. Look for the multimers. Intensity may be reduced, but if you see a normal pattern or an abnormal pattern, you see a normal pattern of multimers or absent multimers. The von Willebrand factors multimers are completely absent, then it goes towards either a 2A disease or a 2B disease. So now do a REPA or see the REPA result, that's called Ristoston induced platelet aggregation. By REPA, if it's low or if it's high, if REPA is low, it tells you it's a 2A disease, and if REPA is high, it's going to tell you it's a 2B disease. Clear? You know that, we have learned this already. Then if you have a normal pattern, it could be either a type 1 disease versus a 2M disease. So if it's a type 1 disease or 2M disease, how to differentiate? You have to see the ratio of what I told you, that is von Willebrand factor, restoration cofactor activity to von Willebrand factor antigen ratios. So if it is more than if it's more than 0.6, I'm going to tell it's a type 1 disease, and if it's less than 0.6, I'm going to call it's a type 2M disease. So this is how we differentiate different types of von Willebrand disease. Clear? Remember, in type 3 disease also, multimers will be absent. Multimers you won't get in type 3 disease also. But suppose in exam, if they ask you how to differentiate between a severe type 1 disease, and a type 3 disease, how to differentiate? There are two ways. The first thing itself I told you, multimer analysis. Multimers will be absent definitely in type 3 disease, there is no doubt about that. But in type 1 disease, definitely multimers will have a normal pattern. So that is one way you can differentiate a type 1 disease versus a severe type 1 disease versus a type 3 disease. But another way is also there, I told you, where your von Willebrand factor propeptide levels will be definitely negligible and undetectable, less than 5. Whereas since type 1, even if it's severe cases, there will be some production of von Willebrand factor will be happening, which means the von Willebrand factor propeptide levels will be more than 5, even in a severe type 1 disease. So these are the ways to how to differentiate sometimes between a type 3 and a type 1 disease, severe type 1 disease. I told you this more than 0.6 is very important to differentiate type 1 from other forms. But there is one other form that also has this ratio in the range of more than 6, that is 2N disease. Here also the von Willebrand factor, restoration cofactor activity to von Willebrand factor antigen assay ratio will be more than 0.6. But anyway, it's easy to find out. The binding assays are the most important. That will confirm it's a type 2N disease. So these are the algorithmic approach on how to diagnose the type of von Willebrand disease. But with this basic background, let us see what is the treatment of von Willebrand disease. Treatment of von Willebrand disease is typically desmopressin. Desmopressin is most useful for type 1 disease, but remember, it cannot be used for type 2 and type 3 disease. The reason why desmopressin is very effective in type 1 disease is because I told you desmopressin works by increasing the release of von Willebrand factor from the endothelial cells. So type 1 disease is most of the times it will be due to missense mutations that reduce the release of von Willebrand factor from the endothelial cells. That is the reason for majority of the type 1 disorders, type 1 von Willebrand disease. So desmopressin will augment the release of von Willebrand factor, and it might even correct the problem that is seen in type 1 disease. That is the reason why desmopressin is most useful in type 1 disease. Clear? But it's not useful in type 2 or type 3. In type 3 disease, there are no von Willebrand factors to release in the first place. So there is no point in giving desmopressin. Similarly, in type 2, it's a qualitative problem, which means even if you release von Willebrand factor, the quality of the von Willebrand factor that is released from the endothelial cells is going to be very, very less. So there's no point. So it's very less useful in type 2 and type 3. So it's absolutely useful in type 1 disease. And remember, type 1 is the most common, 85%. So it's very, very useful as overall if you see in von Willebrand disease, because it's useful in type 1 and type 1 is the most common. So next is type 2 and type 3 disease. You need to find a way out, isn't it? So what are the ways to treat a type 2 and type 3 disease? Very commonly in severe case of type 2 and type 3 disease, the only way out is you have to give a von Willebrand factor replacement. Replacement of von Willebrand factor. That is the only thing that will be way out in severe forms of these diseases. So typically it can come from a cryoprecipitate which has a decent quantities of von Willebrand factor, and you can give factor 8 concentrates which are enriched with von Willebrand factor, because factor 8 concentrate means it also should have von Willebrand factor that is carrying this factor 8. So they'll have a good amount of von Willebrand factor. Or you can use this recombinant von Willebrand factor concentrates also. That is also available, but very like costly and not available in India as such right now. But cryoprecipitate is very easily available in India, so you can use that. Then there is another agent called tranexamic acid. So this is an adjunct to any form of von Willebrand disease during the time of bleeding, because it's an antifibrinolytic, you know that, and it's going to be useful for any form of von Willebrand disease, but as an adjunctive therapy only during episodes of bleeding. That's it. Now let us see the differences between hemophilia and von Willebrand disease. Let us see differences between hemophilia and von Willebrand disease. First of all, the basic difference is the fact that it is X-linked recessive. It is autosomal dominant very commonly, or it could be autosomal recessive in some case, but definitely not X-linked, which means since it's X-linked recessive, majority of the affected patients will be female, and those gender that is severely affected is also a male gender. Whereas in von Willebrand disease, there will be no much gender difference, but if you ask who will be severely affected by von Willebrand disease, that will be female. There are males, here females who will be severely affected. Then bleeding wise, hemophilia will present like a coagulation disorder, you know that, especially deeper bleeds like muscle hematomas, then hemarthrosis, huge limb spanning ecchymosis. That's how they present. But here von Willebrand disease is going to present like typically a bleeding disorder, even though this is not 100% the case, but they present usually the bleeding disorder like feature, like mucosal bleeding, excessive bleeding from skin cuts, prolonged bleeding after tonsillectomy, prolonged bleeding after dental surgery, tooth extraction. All these things are going to be the usual presenting features of von Willebrand disease. Now let us see what will be the platelet count. Platelet count will be usually normal in hemophilia, but can be normal or decreased. Remember, normal in all the forms of von Willebrand disease, but decreased only in one form, that is type 2B disease. But apart from that, platelet count tends to be normal here. Then PFA 100 tends to be normal in hemophilia, whereas PFA 100 tends to be abnormal in almost all the cases of von Willebrand disease. But again, I am telling a exception in type 2N disease where PFA 100 report may be normal. Then factor 8 levels tend to be normal in case of von Willebrand disease, whereas it tends to be decreased severely in case of hemophilia. Here it can be, in von Willebrand disease it can be normal or only mild reduction will be there. But remember, again it can be severely reduced in type 2N and type 3 disease. Clearly it will be very much reduced. And what about your APTT? APTT levels will be seriously elevated in hemophilia, whereas APTT levels will be normal or only mildly elevated usually, but again it can be seriously elevated in 2N and 3 disease because of complete loss of factor 8 in these conditions. Clear? And as such, your REPA, restores induced platelet aggregation, will be normal here, whereas REPA can be abnormal, decreased in most of the case of von Willebrand disease. But remember, exception is type 2B, where REPA may be increased, restores induced platelet aggregation. Then I told you almost all the points, right? So what are the von Willebrand factor levels that we didn't see? Von Willebrand factor levels tend to be normal in hemophilia, but von Willebrand factor levels will be definitely decreased in von Willebrand disease. But one exception is type 2N disease, where von Willebrand factor levels may be completely normal. It's only a problem of binding with the factor 8, that's all. So, but in general, von Willebrand factor levels will be reduced. But one simple thing that both will have is the PT-INR. This will be definitely normal. The prothrombin type and the INR will be surely normal in both von Willebrand disease as well as hemophilia of any form, doesn't matter. So definitely they will be normal. So these are some of the differences between hemophilia and von Willebrand disease. And with this we are completing this very important chapter on von Willebrand disease. In the next section we will be discussing more about the probably the stem cell transplant, and subsequent sections will move on to the transfusion medicine.